So
Let me give you a quick intro and we'll get going. So thanks guys for coming. Today we have Bracken Armstrong, one of our ACCS acute care and C-STAR surgeons, who is here to talk about, I think, a pretty fun topic and something that we probably don't talk about enough, and that is burn resuscitation. Bracken is burn trained and definitely one of our experts here at WashU, and always someone I go to when I have burn questions. So with that, Bracken, the floor is yours, and teach us all about burn resuscitation today.
Thanks, Justin. So again, yeah, my name is Bracken Armstrong. I've been at WashU now since 2018. I did my fellowships, including a burn certificate from Vanderbilt, and I did a lot of burn in my residency in Vegas. It's one of my special interests. So today we're going to be talking about fear of the fluid creep, colloid and burn resuscitation. We'll go into what fluid creep is. Maybe some of you haven't heard that term before. And we'll talk about colloids and potentially ameliorating fluid creep and eliminating it potentially altogether. I have no disclosures. I am a active duty member of the military, but I have no financial disclosures, and these views do not represent the views necessarily of the Department of Defense or the DHA, though I do have a bias towards clinical practice guidelines put out by the Joint Trauma System, which we'll talk about a little bit here. We're going to talk about the history of burn resuscitation, what fluid creep is, and sort of when that term came about in the early 2000s. What is the ideal formula for burn resuscitation? Talk about colloids and the evidence behind it, and potentially rescuing a patient from fluid creep or over resuscitation. And we'll talk about takeaway points in a future study that's hopefully coming out next year that will potentially add more robust evidence to this question about colloids and burn resuscitation. So even as far back as the 1700s, people recognized that burn injury was leading to a loss of fluids. But the first enema was given in the 1700s by Gerard van Swieten, who is a Dutch doctor, who's actually a doctor for the Holy Roman Empress at the time, and sort of transformed the Austrian medical system. And then there's not much in the literature up until the mid-1800s, when a German pathologist, who is sort of a pioneer in military tuberculosis, noticed that the severely burned military patients were reacting similar to how cholera patients would in regards to their fluid loss, and he was advocating giving them saline. Later on, another German, Tappenayer, determined that an examination of dead victims from burns, that they were hemoconcentrated. And he postulated that this was due to a loss of plasma from blood leading to edema in the tissue. And in the 1920s, Dr. Frank Underhill, who is a PhD and a prolific researcher at Yale, including during World War I on chemical warfare and the burns associated with it, later on determined that the fluid in blisters of burn patients the components were very similar to plasma, and that the fluid losses associated with burns cause blood concentration changes. In the 1940s, well, I shouldn't pass over this. And then, of course, the American surgeon pioneer in surgery, Alfred Blalock, who we should all know his name, in his studies on shock, he determined that the local fluid losses of plasma seemed to be leading to the shock and burns. And during the 1940s, the size of the burn, like we do today, really wasn't considered. At the beginning of World War II, hemoglobin concentration and hematocrit of peripheral blood was actually used to determine how bad the burn was. So for each degree of hemoconcentration, which we use all the time now as a marker of hypovolemia, would basically determine which type of volume they would use to restore the intravascular space. But these formulas were fraught with issues and under resuscitation during that time. So during the 1940s, what they were actually using for resuscitation based on hemoconcentration was plasma. And that was sort of the early days of burn resuscitation. There wasn't a surface area established until people were burned during the attack on Pearl Harbor. And the National Research Council started advocating using surface area in the combination of both plasma and salt at that time. Whereas in Europe, they were using, again, more colloids with dextran in Sweden in burn resuscitation. In the late 1940s, one of the first burn formulas came about by Cope and Moore, and this was related. This was at Mass General via Harvard. There was a very large fire and the Coconut Grove fire, where over 492 people died. It's the second deadliest single fire building up until that point in the United States, and they had an opportunity, to treat many burn patients, and they later published this first formula that involved a combination of colloid and a crystalloid solution, where half was colloid plasma and the other was this crystalloid solution. And they came up with this formula you can see here, and they also recognized that the burn resuscitation, the volume seemed to be the most important in the early phases of the resuscitation, and you can see that they gave half in the first 8 hours and the next half in the last 16 hours, which you all might recognize as something we continue to advocate, or we had continued to advocate for many years. One thing they also noted was that the fluid that was coming out of burns, again, was very similar to plasma, and these patients seem to be leaking protein from their intravascular space, not just from the burn itself, but into the surrounding burn tissue. But they also cautioned against their formula, saying that the formula seemed to resist restraint, essentially, and that if you stuck to the formula blindly without monitoring the patient, that you can actually make things worse. And we'll talk about that more as we go on into fluid creep. They actually advocated a new formula. You don't have to go too deep into that. It's a lot of calculations, but the basics is that they advocated for even more plasma during that first 24 hours in particular. They also, during that phase, continued to use hematocrit and protein concentration, but they found that the most important factor actually for them was monitoring the urine output, which is a sign of end organ perfusion. And that's where this actually first came about, was during the 1940s. Everett Evans from the Medical College of Virginia in 1952, his formula is as follows: use plasma, and it's sometimes used whole blood as well, and a half of crystalloid solution. You can see the calculations they did there. One thing they warned about is not exceeding this formula for big burns. They thought that over-resuscitation was going to be a problem. And then the original Brook formula, which is not necessarily what we use today in any way in the military, was also a combination using colloid. The problem at that time, at least in the 1950s for the military, was that the plasma at that time was giving very high rates of hepatitis. And so the military at that time was using alternative colloids, gelatin, dextran, and polyvinyl pyrrolidone. So for that reason, they never used plasma to the infectious rates, but they did use whole blood. And you can see the calculation there. One thing to emphasize too is that colloid was actually given in the second 24 hours of resuscitation. This is just a picture of their estimated fluid requirements and how they broke it down, most in the first 8 hours, next in the second quarter, then a quarter. And they supplemented with glucose solution either by mouth or IV. In England, in the United Kingdom rather, this was a formula that was used for many formula throughout the 1960s, 70s, and some of the 80s. And this is the Mir and Barclay.
Hello, sir. How can I help you?
Also involved reconstituted human plasma.
Yes, I have 3. I will go to 4.
Resuscitation into 4.
Sure, of course.
think Manilo's iPad is on mute. Okay, maybe it's muted now. So the basis of what I'm trying to show you here is that there's a long history in the 1940s, 1950s of the use of colloid in resuscitation. That changed when the all too famous or potentially infamous Parkland or Baxter formula came about with the very famous Dr. Baxter and Dr. Shires. So this was a combination of lactated reners and plasma, which many people forget that the original Parkland formula, still never been modified, is the use of plasma in the second part of the resuscitation, the 4th, 8th hour. And so the classic 4 mLs per kg per TBSA, where the half is given in the first 8 hours, half over 16, at least predicted. And then plasma was actually given 24, 32. But years later, during this resuscitation, the NIH consensus summary on fluid resuscitation decided to omit colloid altogether. And part of that was related to the fact that they felt that crystalloid resuscitation alone seemed to be adequate. And this was a consensus for burn resuscitation for over 25 years after this came out. There were some outliers, though, during that time frame, and in particular, there's the Westpan, also known as the Slater formula, after Dr. Harvey Slater, and they still do that to this day, including at Ohio State. They use a resuscitation involving FFP, and at 75 mils per kg, and it was supplemented with LR, and they titrate that to urine output and continue it for 48 hours. Later, the military, in relation to issues with resuscitation seen in Operation Enduring Freedom and in Iraq, noticed that they had sort of a disarray in how our deployed, potentially inexperienced surgeons were treating patients, came up with a protocol modifying the Brook formula, de-escalating the amount of early resuscitation of crystalloid, and then asking that albumin be given at an hour mark, hopefully no earlier than 12 hours. And that clinical practice guideline has subsequently been revised many times, and I personally think is one of the best protocols available to us now. So why am I talking about colloid? Why am I talking about the history and sort of the transition of colloids to crystalloid over the hundreds of years now of burn resuscitation? Well, the very famous, sort of legendary trauma burn surgeon, Dr. Basil Pruitt, who was the director of the United States Army Institute of Surgical Research for almost 27 years, since 1968, and then went to the UT Southwestern, came up with a sort of a pinnacle paper about, really just an opinion piece, rather, about how he coined the term what's called fluid creep. And at the time, there was a number of very disturbing reports that many burn patients were receiving much more resuscitation fluid than predicted by the widely accepted formulas that I've listed, be it the Brook or Parkland or any other that was crystalloid based. And not coincidentally, there seemed to be a trend in the literature and reports, widespread reports of abdominal compartment syndrome. He basically said we need to start pushing the pendulum back of over resuscitation, and I'll go through some of that data that he's talking about. Similarly, that year, Michael Ivey, who is another Yale physician, noticed that 70% of the adult patients with major burns were developing transient intra-abdominal hypertension during their resuscitations, and that fluid mark that he was noting was the 250 mils per kg of IV fluid. That as they approached that volume, they were basically having intra-abdominal hypertension, which that mark is normally 25. People now call that the IV index for resuscitation. So it's a very important number to try to avoid, that people have recommended during your monitoring resuscitation, that when you need to start pushing that pendulum back of what we call fluid creep. So why is it important? So it's a modern problem. It's a modern problem that since the 2000s, there's been a lot of push to avoid, but it still occurs when you don't appreciate it's happening, and it's very frequent. 30 to 90% of patients, especially with bigger burns. And what's noticed is that the more fluid you get in the beginning, the more fluid they're going to get at the end. And it seems that the more fluid you give, the more fluid you're having to give to as you create more edema. You want more fluid to try and augment your organ perfusion. And that IV index should prompt measures to correct it. We're going to talk more about that. Complications, obviously the need for abdominal compartment syndrome, which we've mentioned, but ARDS, pulmonary edema and respiratory failure, and also extremity compartment syndrome, potentially worsening the depth of burns through ischemia. And we should note that it's not just fluids that cure burn shock. It's more important that we're augmenting appropriate cardiac index, but not fluids don't necessarily always correct that in every patient. There has to be a certain comfort level with resuscitation. So what people were noticing, this is just that data that was coming out during this time, during the early 2000s, and this paper by Friedrich. This is from the University of Washington, Seattle, where actually two of my burn mentors have been trained. And what they
44 admissions waiting to go up.
Yeah.
You can't get anything done.
And it's 45 away.
He's unmuted. Okay, no. So they compared, again, small study, 11 patients in the 1970s versus their 2000 resuscitation. And what they noticed is that in the 1970s, they were giving much less fluid. You can see that dramatic difference, 3.6 mils per kg versus the 8 mils per kg in the first 24 hours. No outcome, did not evaluate outcome differences in this study. It's just a simple reporting of values. Another great burn surgeon, University of Utah burn surgeon, very well respected on fluid creep. He thinks there's 5 reasons really that we're tending to over resuscitate in the modern era. One is that we're teaching people better. We're outreaching better about burns. People understand that big burn involves fluid loss, but with that there's an overzealous nature, maybe a lack of understanding, which I see all the time, about how much fluid is too much fluid, how much is too little in the early phases of resuscitation or the early post-burn period. In particular, what he mentions and what I've seen through practice is that there's a lot of bolusing. Similar to the ACLS protocol there in trauma. So we're going to bolus 2 liters, the old ATLS, principle. And so which you should really never do to a burn unless they're hypotensive. As well as this is a classic problem, is that burns size is often overestimated. So there's often too much fluid given. For example, calling a 1st-degree burn a 2nd-degree burn when it isn't. Second is the advent of goal-directed resuscitation in critical care, which doesn't necessarily apply as well to the burn patient, especially in the early post-burn period. They're very unique in regards to their restoration of cardiac output and cardiac index. It just it will not normalize in a big burn until 24 to 48 hours post-burn. And so the attempt at excessive resuscitation to give you normal cardiac index and cardiac output is fraught with danger. And then the prejudice against colloid since 1979, and the ongoing prejudice of colloid in the 2000s related to a number of Cochrane reviews, which we're going to talk about. And during resuscitations, I think clinicians and potentially nurses are, when you have a protocol, are much more likely to be worried about low urine output and turning fluids up than they are to turn them down when your urine output is adequate or more than adequate. The UT Southwest, the Parkland folks, they have another paper, 2008, and they examined their own data of 483 patients in the 1990s and early 2000s. They found that most of the patients they looked at were over resuscitated. They seemed like then another 43% were adequately resuscitated, but there weren't necessarily differences in morbidity and mortality. Also, though, at that time, they were using a significant amount of colloid. They wanted to emphasize that, yes, Parkland isn't necessarily dead, but it's a good starting point. But you have to resuscitate based on the individual needs of the patient hour to hour. And which I think sometimes people don't forget when they look at that Parkland formula. But even Baxter's and Shires mentioned that in the 1960s and 70s. So looking at all that and the idea of fluid creep, do we actually have an ideal formula that in the United States? Crystalloid as of 2010 was still the #1 resuscitation formula. And as most of us know, that crystalloid utilizes LR, though some people use hypertonic saline and as adjuncts. Very small percentage at that time were using colloid and plasma, including that Slater formula, which I mentioned. About 90% of those formulas, they just use to get started, and they use not urine output as the primary endpoint of resuscitation. But many of the centers surveyed in this study, about 1 in 2 were using colloid during that first 24 hours to augment their resuscitation, including a small amount that used FFP. Surveys of burn centers at that time felt that the formulas provided was overestimated the formula predictions, and that at the time that they felt that the formulas were just right, but that they felt that small amount felt that they were overestimating the amount that they needed. So there's kind of is a disparaged question, but the basics is that they recommended the formulas are only, again, and we've mentioned this, just a starting value, and that you have to base your resuscitation on the physiologic needs of the patient, and you can't just stick blindly to the formula, which is a major error. In 2021, another very famous UC Davis burn surgeon, Dr. Greenhalgh, abrupt study came out where this is a prospective trial surveying number of burn centers on their use of resuscitation. And during this time, some 11 years later, there was a much higher use of albumin resuscitation. And what they noted is that patients who were resuscitated albumin were actually receiving more fluids. But that those patients were usually older. They usually had much larger burn sizes, and their admission SOFA scores were higher, and they usually had inhalation injury. But when they did start albumin, most centers were using it as what we call a rescue. And when you did start albumin, you were improving what's called the in-to-out ratio, which I'll show you what that is in a short. But that's basically your ratio of fluids in, the urine output out. And the restoration of in-to-out ratio, which should be between 0.5 to 1, is a great sign of an appropriate resuscitation. So what's the evidence behind colloids, and why are we thinking about sort of bringing them back into the fold? And they're here. It's just a matter of sort of your knowledge of why we're bringing them back into the fold. And the evidence is unfortunately small. The evidence is involving a number of papers that are not necessarily prospective or randomized. And so we're gonna talk about a few of those. But this is the basic idea behind its use. When you're burned, a lot of people think, oh, you're losing a lot of that insensible loss from the open skin itself. It's actually a huge contribution of your fluid loss is the leakage and accumulation of plasma proteins from capillary leak and a loss of intravascular pressure through a huge amount of third spacing around the burn or at the burn and in the entire body. And that leakage is of protein is quite profound in that first 8 to 12 hours. But there's a sucking, what's described as a sucking interstitial pressure that persists even past that point of loss of protein. And so fluid escalation for those who have resuscitated a big burn that escalates in that time period is a hallmark of developing fluid creep and the need for rescue. And the idea behind colloid is that you're going to increase your intravascular osmotic pressure reduce that leakage, reduce your crystalloid resuscitation value, pull fluid from the interstitium, and reduce your edema formation or third spacing, and restore your in-to-out ratio and restoration of end organ perfusion. And then there's a number of parties about this. The people who are pro-colloid, they think the evidence suggests it reduces volume of fluid for resuscitation, decreases your over-resuscitation, improves that in-to-out ratio, maintains your urine output higher than crystalloid alone in rescue, and then it supports your cardiac output and doesn't necessarily increase your risk of ARDS. And because some people believe, based on some literature, that giving albumin result in increased pulmonary edema, and then increased, as that albumin leaks, increase edema in other tissues, which is part of that anti-colloid claim, excuse me. Anti-colloid claim, they say don't give it in that immediate post-burn capillary leak, and that it's not retained like any greater than electrolytes. It costs much more, and we all know that. It doesn't necessarily change cardiac output. Again, may be deleterious to lung tissue water, and we'll talk about this small study where people latched onto that for many years, probably still to this day. The plasma, if you're using plasma, of course, there's infection and transfusion reaction risks, and there are Cochrane reviews that say that albumin may increase mortality. Colloids, this is that study, 1983, good one, a paper that's highly quoted in the literature. This very, very small study, they had 29 patients examining cardiac output resuscitation with albumin versus LR, and then also examining the lung water using a very sort of unique non-invasive rebreathing technique. What they showed is that patients who got LR did in fact get more fluid, and that albumin did in fact actually restore cardiac output more readily, but the albumin group accumulated more lung water post-resuscitation. This small study has influenced resuscitation practices for years, perhaps, and this is per Dr. Saffold, perhaps excessively so, as more recent trials have shown no differences in the outcomes with colloid use. But this was a very important paper for burn resuscitation for many, many years. In Israel, they were using a protocol for many years that involved plasma, and what they showed here is that the use of plasma actually showed a lower incidence of ARDS than the literature at the time in the years past, and also a lower incidence of pneumonia. They felt that resuscitation with the low volume formula that consists mainly of colloids could actually reduce the incidence of ARDS and pneumonia in this small study. Another is Israeli hospital using plasma and resuscitation in combination with LR. They noticed less fluid requirements than estimated by Parkland, no fluid overload complications. And then these numbers here, basically non-inferiority numbers, very similar numbers to what was in the literature at the time in regards to respiratory complications, sepsis, mortality. So not necessarily an advantage, but a non-inferiority and less fluid. This is an important Cochrane review that came out. It wasn't just burn patients, but it was critically ill patients. And basically no evidence that showed albumin administration in critically ill patients across the board with hypovolemia, burns, or hypoalbuminemia would result in a mortality difference. And actually there's a strong suggestion it may increase the risk of death. This was sort of an anti-albumin moment. Based on the evidence of the time. Later, the folks, again, using the West Penn formula, Slater formula, brought in Parkland versus their...
Initially had blood pressure down in like the 90s, systolic or so, but then his...
And what this showed is that they felt that the crystalloid alone resuscitation, the evidence showed that it actually increased the intra-abdominal pressure more on a mean of 32 during the resuscitation versus a mean of 16 with the FFP and LR combo. And they had to administer significantly more volume in the Parkland formula alone versus the Slater. So another, again, small study, 31 patients. Cooper and his colleagues comparing 5% albumin versus LR, very small protocol. The basics here is a non-inferiority study, just showing no difference in multi-organ dysfunction or mortality. This wasn't necessarily unsafe or safe in this very small series of patients. Now, the military data, again, we talked briefly about that. After in Iraq and Afghanistan, there was a need to make a standardization of clinical practice for deployed individuals who were seeing a lot of bad burns and not necessarily having a lot of experience with burns. And so early on in the early 2000s, around 2005, the Brook formula was modified and made into a clinical practice guideline, including albumin infusion, again, around the 12-hour mark if they felt a rescue, or earlier if they felt they were approaching the IV index, essentially, of 250 mils per kg. What they showed in their initial study is that it appeared that introducing this standardized protocol was reducing their mortality. They were lowering their abdominal compartment syndrome and using the modified Brook formula. Later, Dr. Chung is another prestigious military surgeon, burn surgeon, was compared the retrospective series of the use of Parkland in these deployed environments versus the modified Brook clinical practice guideline. They were finding that the Parkland patients were getting much more volume of fluid. You can see that nearly 2.1 liters difference per milliliters per kilogram difference, and that there were a large portion of their patients were getting albumin, but there was no difference in outcomes overall. They basically suggested there may be a decrease in the resuscitation morbidity with albumin from this, but it's more important that just establishing a protocol seemed to make a difference. Important colloid rescue paper, and this is sort of what I think most folks now in the burn community think of colloid as, is 52 patients. Basically, if patients were approaching the IV index of over a fluid creep, they would do an albumin rescue. And this is still fairly widely practiced at a number of institutions. Basically, if you approach the fluid creep numbers with Parkland alone, you would get an albumin rescue. And they compared patients who when they introduced the albumin rescue versus when they were just using crystalloid alone. And the albumin rescue involved a third of the hourly fluids of 5% albumin. And what they found is that albumin rescue was used more frequently in big bad burns when they had inhalation injuries, and patients that were, of course, larger in and out ratio. So they were getting much more in than they were getting out. And what they found is that in these patients produce a dramatic and precipitous return of that in to out ratio. And it felt that it fixes fluid creep. Here's an image from that paper where you can see the sort of the difference in the in to out ratio once colloids introduced. This is sort of an easier one to understand. You can see that 0 hour versus 2, 4, 6, 8 hours as you approach the table going right. Once colloid is introduced, you can see the in to out ratio quickly normalizes in their patients. So again, another Cochrane review. This is the most recent one that came out in November 2011. Again, suggested, based on the current literature, no evidence that albumin reduces mortality and compared to cheaper alternatives in saline critically ill patients with hypovolemia. And that there was no evidence that albumin reduces mortality in critically ill patients with burns and hypoalbuminemia, which is understandable based on sort of the literature you guys have seen so far. Retrospective studies, poor, if any, prospective data, not very randomized. Alternatively, 5 years later, this group, including Dr. Greenhalgh, did a meta-analysis where they actually exclude some of the literature that they felt was more heterogeneous in their than the Cochrane review. They also include, though, in this study, a number of non-randomized retrospective trials. And they felt from that literature that the albumin infusions actually reduced mortality and did in fact decrease the occurrence of a morbidity compartment syndrome. Again, stating that the quality of that current evidence is limited. These are that studies they included there. And you can see some of them are almost, when this study was published, were almost 30 years old at the time and not involving a significant number of patients, except for Cooper in 2006, which we talked about. A similar group sort of examined that data a little differently. They felt there was no mortality benefit for albumin, not necessarily mortality increase, but no mortality benefit, but that the total volume of fluid was in fact lower if albumin patients required it. Again, limited evidence, low power. Another rescue albumin paper, basically, if you fail to respond to crystalloid resuscitation, you met their criteria, if their urine output was less than 0.5 ml per kg for 3 consecutive hours, and unstable vital signs or an increased fluid demand, they often gave 25% or 5% albumin in this study. And what they felt, what they saw rather in their patients here, 91 patients, decreased amount of fluid, increased end organ perfusion, no increased rates of respiratory failure, no increased rates for need for CRT, but that these patients were getting longer stays in the ICU. In hospital stay, they felt they were, more widely burned. Usually, were these patients more sick because they required rescue. And overall, though, no differences in mortality. So, what's the future? I think we need a prospective randomized trial, and thankfully it's undergoing. The ABRUPT-2 study, the acute burn resuscitation trial. With you see Davis Legend is here, but he's about to retire. I think he's going to go out with this one. So, but they're comparing LR plus 5% albumin as rescue, and then that third albumin to 2/3 LR ratio, with a 25% TBCA, so relatively big burns. Hopefully this is going to come out September 2024. Look forward to it. I think it'll maybe give some people give more comfort about this still controversial topic based on the literature we have available. So takeaway points, fluid resuscitation, we know it's paramount in the first 24 to 48 hours, but how you do that and what formula you do it is still controversial. And the proper fluid composition, the volume, controversial. But fluid creep is real. It's a modern problem, and there's the 5 reasons I mentioned. And those things can still be addressed, including pre-admission resuscitation, being vigilant about both reducing fluid and increasing fluid. Realizing that colloid was part of the, there has been a anti-colloid resuscitation paradigm going on, and that potentially, even though there's not a clear association with mortality, despite the Cochrane reviews, it seems to benefit patients with larger, more full thickness burns, patients with inhalation injuries that are expected to have longer length of stay, that are approaching the IV index. And as you approach the IV index, you're going to get intra-abdominal hypertension. You're at risk for abdominal compartment syndrome, which we should always try to avoid in these patients, and of course, and that you can potentially stop fluid creep with albumin based on the current literature available and based on current expert consensus. So I hope that we see some more randomized control trials after ABRUPT-2, and I hope that it shows some positive data for this resuscitation method, but we will see. The other thing is that, when you resuscitate these patients, you need to have you just need to have a clear protocol that everyone supports. So if people do it many different ways throughout the country, throughout the world. And so I think if you have good buy-in and consistency, you should hopefully see positive outcomes for your patients. I like this protocol. I'm biased for the joint trauma system because I think it works. And it is based on this evidence that, albeit limited, that we've presented here. My references and any questions.
Well, thank you very much, Bracken. Fantastic talk. And I love all the points that you brought up. I love going through the history of burn because I think it's actually really important to figure out when we talk about these formulas, and first realizing that the one that we all know is Parkland is like 50 years old and has hardly changed. And the fact that as much emphasis has been placed on Parkland, almost nobody knows about that second 24 hours and that, the fourth 8-hour period. And I think, this reminds me a lot of whole blood, where I feel like, we go back to our roots and we see that initially the way burns were treated was with plasma and albumin. And just like whole blood, I feel like we're having to reinvent the wheel to go back to the roots of how we initially started treating these disease processes. As someone who hates albumin overall, this is the one class of patients where, you look at it as a disease process and it totally makes sense. And the evidence does kind of back it from a thought perspective. This is how it works. The body is, it's like a good microcosm of understanding fluid resuscitation. And so, no, someone just walked in so I can hear myself talking in the background. So I think we can use this as an example for the rest of trauma, understanding fluid resuscitation. We've spent most of our time in burn, it seems like, on fluid resuscitation. I think we need to do it in other areas of trauma. So I know there was a really good question that was brought up by Manny. He asked, basically, are all colloids equal? And I know you talked about plasma and albumin, and I know we often kind of use them in burn a little bit interchangeably, but are they? And do you see that going one way or another in the future?
That's a good question. I think they're not all equal. I know that the Germans and the Swedish are still using dextran at times and alternative colloids. I think that the Slater formula, which the West Penn still uses, fresh frozen plasma. I'm personally hesitant about giving something that has the potential for more immune reaction and not, than albumin, which doesn't necessarily have a demonstrated immune reaction from the FDA, and the infectious risks associated with it. And as well as potentially the limitations of plasma, though we were just on a albumin shortage less than a month ago, I think, right? So the short answer is I think we don't know. I don't think we really have a randomized controlled trial to demonstrate a superiority or non-inferiority or inferiority between colloids at this point. But we do have demonstrations of positivity with both plasma and albumin in the, again, small studies that we showed, including the group from Slater and the group from Utah.
I was looking at the chat. I didn't see any other questions in the chat. Does anyone else have any questions or comments?
I had one. Thanks, Bracken, for doing that. Very comprehensive talk, a lot of moving information there. I kind of had two questions based on this, and this is just, I'm not familiar with it and may have already been explored, but your concept of the sucking interstitial pressure thing, it doesn't seem like that's going to get solved by giving something internally endogenous, like that entity is still going to be there. So mine leading to, is there anything that's, I know we put dressings on and try to change those and things like that, but I think, is there a way to potentially combat that, like either I think of after they pulled Luke Skywalker out of that tauntaun and they have him hanging in that water bath type of thing. Could you like have something like that that creates a low pressure externally, or like you think of mesh trousers or something like that? Is there like a low pressure external means that's been explored or look at to like overcome that from the other direction instead of us infusing? And then the second kind of lead on to that was, even if patients aren't hypotensive, is there any role for when it becomes vasoplegic or more vasodilatory, like low dose pressor, not to hypoperfuse the end organs or anything like that? You wouldn't want to run that worse. But yes, we're giving all this fluid to prevent leak, but is there anything to be gained by getting a little bit of tone in addition to that? So those are kind of the two questions.
Both are great questions, and I think both are have been addressed and tried to be addressed in the. I can't remember if it was the 1930s or 40s. They were actually trying to do compressive wraps on the patients so that the edema formation would be less. And what they were finding is that, including like splinting these patients so that the edema wouldn't potentially not form. And what they were finding is they were getting ischemic limbs. And so that has been, at least from the compression standpoint, has been attempted and subsequently abandoned. I don't think I'm not familiar with any recent literature on it. The idea of like an atmospheric change is sort of interesting. I don't know if that would necessarily stop your interstitium from still having a significant amount of protein and then still pulling a hypoosmolar fluid towards it. And that part of that reason that the colloid is now recommended around the 12-hour mark is that the thought is that you're not going to leak it as much and create more edema after that that protein leak is the most, even though you still have that suck present, as the literature describes it. The second question is about the pressors and the joint trauma system, which I think they have a nice, really elegant paragraph on this, and it mentions once you reach the point where you're oliguric and you're also hypotensive is the avocation of pressors, and then they advocate actually vasopressin, which is sort of interesting as a choice, but they actually recommend vasopressin first, followed by norepinephrine. And they basically, once they say that you're oliguric and based on your dynamic measures of fluid responsiveness, you seem to be euvolemic, that there's, at this point, the cat's out of the bag and you have a renal insult. And so you need to, rather than advance fluids further, continue to monitor your dynamic measures of fluid responsiveness, including point of care ultrasound on the heart, if you can get a good view, and sort of let things sit. And at that point, add albumin as well as another consideration. So in addition to your pressors, but they caution strongly against trying to augment excessively beyond your current ability to create a level euvolemic cardiac output by adding more fluid, which I think we all understand. But I think many people, they say, all right, we're not making urine, we're just going to keep ramping up the volume. And that's how you create abdominal compartment syndrome. You have to basically say, all right, well, what's going to come first, lungs, abdominal compartment syndrome, or dialysis? Eventual dialysis, rather, because usually most of these patients don't necessarily get hyperkalemic and severely acidotic right away and need CRT, though plasmapheresis has been advocated in the early resuscitation phase in some studies as an alternative.
Cool, thanks. And if nobody else asks anything, I'm going to say, what about dialysis folks that get bad burns and you throw out the urine output?
One more question.
Yeah, Manny.
Question. Does sedation and/or analgesia matter in terms of how it affects hemodynamics?
Yeah, that's another point the University of Washington folks have talked about, and they talk about opioid creep, and they think to your point that based on retrospective review of their data, we are giving way more opioids than we ever have for big burns. And the thought is that yes, there's an augmentation of the need for resuscitation based on the fact that we probably more of these patients are being intubated than they were in the past, and we're giving a lot more opioids and sedatives than we were in the past because of different practice patterns. But also our survivability is much higher in burns than it ever has been in the past. And a lot of these bigger burns would die as opposed to the mortality reduction now, which is quite significant. So it's a good question. And I think, yes, the short answer is yes, there has to be a contribution. And it could be part of the modern problem, the fluid creep. I didn't dive into that one too much, but yeah, it's absolutely mentioned many times in literature.
And is ketamine historically used to be one of the agents of choice for burns? Is there any reason to change that mindset? I think it would still make sense to use ketamine in these patients, but is there any reason why this may not be the case anymore?
I think it's a great medication for a burn. Analgesic, amnestic, potentially pro sympathetic. So I think no matter what, if you're under resuscitated, you're under resuscitated too. So I didn't talk about high dose vitamin C. A lot of that's in animal data and guinea pigs and sheep. There are some human controlled trials about it, but there's thought that right now it's not really heavily used in the field. They think it's actually a diuretic, among other things, and that you may be augmenting your urine output through that. I'd be amiss in not mentioning hypertonic saline just at the end here, because for those who know Barnes history, Dr. Manafo was the chief burn surgeon here for many years. Worked at Mercy Springfield, was also known as St. John's at the time. Was a chief surgeon there, burn surgeon here, trained here. He's the guy who did many of the studies in the 1970s and 80s about hypertonic saline, and did show a fluid reduction. But there's hypertonic saline's out of favor these days due to the risk of hypernatremia and possibly worsening acute kidney injury as well. So it's dampened the enthusiasm for hypertonic.
Any other questions?
Nice review.
Yeah, I think it wasn't the main focus of the talk, but going through the formulas and especially emphasizing how these are starting points, and the urine output still seems to be the end all be all in terms of how we're titrating our formulas. And I know I've been asked this before, do you ever see that changing? It sure seems like at some point we're going to find something better.
Yeah, and I think urine output is just one marker, right? I think we can continue. I like monitoring your hematocrit still, which is what they did in the 1940s. If you're seeing hemo concentration, it's a bad sign. You have to be not just monitoring urine output, but monitoring your in to out ratio. And I think using your just being incredibly comfortable with putting a probe on someone and using your dynamic measures of fluid responsiveness the best you can, be it an inspiratory hold or expiratory hold or a straight leg raise or whatever it may be, and following your pulse pressure variation. I mean, most of these patients are going to be hyperdynamic, but trying to get them not super normalized from a cardiac index, cardiac output, but at least normalize as best you can, because you're not going to normalize in the beginning. And it's just like in shock, and all of our shock, right? We have to be comfortable using all that data points and coming to the best conclusion we can. The other thing is there's a thing called a burn navigator computer programs that makes it easier for the nurses. It actually sends you a little color code. And I think it just you dumb it down a little bit and you make it easier. So you actually have a reaction to over resuscitation as opposed to, we're good, urine output's good,
Yeah, and I think that's, all those points in terms of it, this takes a lot more vigilance. I mean, this is really the epitome of resuscitation and with fluids. It's, what I see is exactly what you say, where it's like everyone says, well, we're good. And it's like, no, if there needs to be changes, we can't be too complacent with it when things look good. That means we still need to make adjustments. So I think there was one other comment that popped up.
Well, I can also verbalize it.
Yeah.
You talked about changes in mortality, improvement. In the big picture, what has made the improvement? What is different compared to, let's say, 20 or 30 years ago that changes outcome? And also, the old formula, age plus % of body surface area burn equals mortality. Is it no longer in effect anymore?
Yeah, well, the that mortality, I think, is still relevant as a baseline prediction. The problem is that original formula, where you draw a line across the chart and it matches up, TBSA matches up with mortality and age. It doesn't necessarily correlate well with inhalation injury and other morbidities. I think beyond resuscitation, the biggest advent is the change in how the timing of debridement and the topical therapies that we've done and the infection control, because most of these patients, by far and large, still big burns, they get septic. And even in the 1950s and 60s, burns usually weren't debrided until the 6th to 8th day post-burn. And now the recommendation is to try and get these patients in by 48 to 72 hours once they're past their large resuscitation phase. Because you have a big burn, you basically have dead necrotic tissue that is at that point, potentially super colonized and about to rot like neck fat. I tell the residents, I think of a burn at 48 to 72 hours like someone who is in the early phases of neck fash. And you need to get them urgently to the operating room and get the dead stuff off. I think the use of hemorrhage control, infection control, and getting an early post-burn debridement probably have made the biggest changes in morbidity and mortality. And then, of course, increased use of grafting techniques. And now there's even a huge change in the augmentation of take of grafts. I know Dr. Kirby's working on getting a product here that a lot of big burn centers use every time on the burns for better take of their grafts. So it's a new world here with burns, I think, all the time.
Well, and I'm putting that down. That actually would be another, talk in the future, talking about the debridements and grafting and all that. Because you're right, it is a fascinating area of burn research.
Thank you.
Other comments, questions? Well, otherwise we are right at 6:30 and right on time. So Bracken, thank you again for doing this. This was absolutely wonderful. And I will send out the invite for next month shortly. Thank you guys for all showing up, and have a good day.